Thank you, everyone, for waiting it out today. And I think Paul brought some champagne, but he told me, honestly, that it was cheap. But I think it's a day for all of us to celebrate, myself in particular, because I remember day one when we infused the very first patient at Duke in 1999 to the product that is currently approved today. And it's really an honor to be part of this process, where today we have more than 1,000 patients on enzyme therapy. Alan asked me really to talk about the infant, and I've tried to do some updates and also some generalizations to the adults, as I think a large part of the audience here is there. And before I start, I think financial disclosure is really very necessary in today's time. So I have received honorarium and research grant support from Genzyme, and my university stands to gain now that Myozyme has been approved, and inventors of the cell line also stand to gain financially. That's not myself, but in terms of full disclosure, I really do believe I needed to state this. So with this, really, I want to say the milestones that we've reached is just until May 2006. We had no treatment other than supportive care, and we've really talked about different methods now, exercise, diet, etc. But I think we all know that these alone cannot really provide the answer for our patients. And Barry talked about this, and so I'm going to try and skim through these and just talk about the long term of what we've seen in the infant trials, just to tell you that this is not just a short-term process, but a long-term commitment and a long-term understanding of now a new treated disease that we have at hand. So of the 18 babies that Barry talked about, 13 out of those 18 still continue to be alive, and this is approximately 2.5 years outside since the start of therapy. And 50% of them continue to be alive and free of invasive ventilation-free survival, which I think is a significant milestone if you think about the process of these babies either being deceased or on a ventilator before a year of age. And then if you look at the more advanced group of patients who were between 6 and 36 months of age when they started the study, some of them really have a phenotype quite similar to what we see in adults with Pompe disease. The only difference was these children also had cardiomyopathy or involvement of the heart. And here you see that 15 out of the 21, or 71%, continue to be alive, again about 2.5 years outside of since start of therapy. And 7 out of the 16 who started therapy not on a ventilator continue to be independent of any form of ventilation. So I think these are important milestones. And once again, to put it in perspective, this is the long term. If you see, this is children without any form of therapy and what the natural history was of the disease. And now when we look at it at the conclusion of the extension study, which was about 2.5 years long, 72% of the babies that started out in the pivotal study continue to be alive. And 50% of them are alive and free of invasive ventilation. So this is a significant milestone, but it tells us there are properties really of the disease that we haven't completely understood that we still need to be tackling. And this is just the cardiac response, and I think as Barry alluded to earlier, a large part of the clinical response is due to the cardiac response, but as we're seeing now in the adults who do not have cardiac involvement, we are still seeing a response. So I think there are many other factors, and of course a skeletal muscle response also does occur, but I think there are a lot of variabilities in who responds and who does not respond. And this is just to put in perspective what some of the children are doing today. So this little boy is actually now 5 years old, but I had done this when he was 3.5 years old. And yes, he does play basketball because he comes to Duke. This is a now 9-year-old child with Pompe disease. This was done when he was 5 years old. This is the first patient from the very first trial that started the trial, and I just had the pleasure and honor of meeting him last week at a meeting in Illinois, and you can see he continues. He's now in 4th grade at school, doing really well, playing baseball, but does have some limitations, which I'll point to towards the end. And then here is another long-term survivor who we continue to see at Duke, and you can see this is the work and the expertise of someone like Laura who doesn't give up. This boy is starting to weight bear, and hopefully one day he will learn to walk. So there is a whole spectrum of response that we see, not just in the short term, but also in the long term for these patients. In terms of the immune response, I want to spend a moment on this before I go to the care of the infant, for the simple reason because I think it involves not just the infants but all the adults also, that about 90% of these children between the two trials made antibodies to the enzyme. So what does that really mean? Is that they had a response, but did it really mean anything clinically? And I think that's the question that we have today. And I have some answers, but not all the answers. So the median age at which they converted or started to make the antibodies was about 4 weeks. And if you look at the group, 6 out of these 39 were actually the CRIM-negative patients, or those who had 2 deleterious mutations, unable to make any enzyme. And here was the first part of the story. They are the ones who had very high sustained antibody titers and subsequently had a clinical decline. And then really, in terms of the dose groups, the numbers were small. There were 9 in each group that were randomized to 2 different arms of the study. The understanding is, or the thought is, that dose did not make a difference and there were more infusion-associated reactions. But we have to remember, small number, so we need to do more studies, and that's one of the post-marketing commitments that Paul alluded to that's currently ongoing for this. So in terms of the immune response, only 3 out of the evaluable patients did not make any antibodies to the myozyme. And now look at the rest. This is one pattern of response where you see a downward trend. So yes, you make the antibodies and then you have a downward trend. Then you have another type of response where you do make the antibodies, you have a downward trend, and you completely tolerize. That's about 74% of this group. And then you have a small group, about 25%, that makes the antibodies and continues to make the antibodies, which remain high and sustained. And some of these, or the vast majority, were CRIM-negative. But what I'm pointing out is a few were also CRIM-positive. So I think this is where our understanding is and where the translation can be even to the adults, that just being CRIM-positive does not make you completely protected from making high sustained antibodies. So I think these are lessons that will continue to be learned as we move along. And the ultimate goal is to try and have some kind of interventions here where you can tolerize the patients so that, yes, they may make a response, but if we can have them come down, I think this is the goal. And of course, the ideal would be a patient who would not make an immune response. But I think the likelihood of this is low, just given the amount of therapeutic protein, which Paul spoke to, is 20 times what we typically give in any other treatment. So now coming to my topic on the multi-system involvement in Pompe disease, pulmonary, GI issues are present, cardiac disease is present, musculoskeletal, and yes, the unanswered question of how much central nervous system involvement is there. And I think a number of these are for the infants, but I think some of these can be extrapolated to the adults. And I would suggest that you read this diagnosis and management guideline, which was a culmination of effort from many, many experts in the field, which clearly has been of great value, at least in the United States, in terms of insurance coverage and in terms of educating the physician who's far away from the expert to be able to manage both the infant and the adult with Pompe disease by following some of these guidelines. And here I want to stress that ERT, and I think Laura talked about this yesterday, is really one aspect of overall care. It really has to be a multidiscipline team approach and should be provided at centers with experience, and this clearly increases with time with new centers coming on board. And it really has positively impacted the outcome by initial intensive and comprehensive care. So the role of the physical therapist, the occupational therapist, the speech therapist, the dietitian, and many more really cannot be minimized as we think about this. And clearly, the disease natural history is unfolding, not just for the infants, but also for the adults, and I'll talk about that too. And so this is really showing the multiple groups of people that are needed to take care of the patient, but at the center of it all, I think it's the parent or the patient themselves and the care coordinator that really should be at the center and should guide and control this.